Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Thank you to the Facial Plastic Surgery and Aesthetic Medicine Journal for the opportunity to share our research via the AAF PRS About the Face podcast. My name is Alex Marston, and I am currently an assistant professor within the otolaryngology head and neck surgery department at UC Davis Health in Sacramento, California, and previously for 4.5 years worked at Tufts Medical Center with my colleague, Dr. Andrew Scott.
My name is Andrew Scott. I'm an associate professor of otolaryngology and pediatrics at Tufts University School of Medicine in Boston. I split my time between Tufts Medical Center and Mass Eye and Ear Infirmary.
Great. We're here today to discuss a paper titled Assessment of Psychosocial Impairment Among Patients with Cleft Lip and or Cleft Palate using the Pediatric Symptom Checklist. This was recently accepted as a research letter in the Facial Plastic Surgery and Aesthetic Medicine Journal. So to get started, Dr. Scott, as the director of the multidisciplinary cleft and craniofacial team at Tufts Medical Center, what have you done to monitor the psychosocial health of your patients with cleft and craniofacial differences?
So there are parameters of care and standards that we have in the cleft and craniofacial world for following kids as you care for them throughout their childhood. And one of those is to monitor them for psychosocial impairment and to plug them in with services such as therapeutic services, psychiatry, psychology, social work as necessary. And when I was setting the team up, I reached out to our pediatric psychiatrists and child psychologists, and they wanted to know, if we were doing any questionnaires or what we were using for screening. And of course, as an otolaryngologist, I said nothing. I had no idea. And so looking into a bunch of the surveys that are out there and screening tools, the first one that I came upon that seemed to be the most widely used was the Pediatric Symptom Checklist. And they indeed confirmed that this is the one they would prefer and that were used in most pediatric clinics, and the data of which is most likely used for generating referrals and sort of advocating the urgency of which a child should be seen. And so this was sort of the language in the pediatric world for these referrals, and therefore we started to implement it. And so every either annual or semi-annual visit, we would survey the kids to determine sort of the state of where they were. So thinking about this as a screening tool, can you, Dr. Marston, sort of talk about the differences and scoring and there's a youth questionnaire and a non-youth questionnaire that's out there?
Yeah, sure. Yeah, so the PSE, again, is a validated questionnaire that can help identify emotional and behavioral problems to assess for challenges in pediatric psychosocial functioning. And for this study, we broke down the patients into two age groups, one that is 4 to 5 years old, and the older age group was between 6 and 12 years old. And that's because for the younger age group, there are 31 that the parent or guardian are asked to answer on behalf of the patient. And for the older age group that was included in this study, 6 to 12 years old, there are 35 items. And so we decided to separate the age groups as such. There is additionally a PSC youth survey, or PSCY, which patients who are between 11 and 18 years old are eligible to complete. These are collected within the Tufts Medical Center Multidisciplinary Cleft and Craniofacial Clinic. However, we did not include these in our study. The questions that are answered by the parent or guardian are rated as never for 0 points, sometimes for 1 point, and often, which is scored as 2 points, and higher scores then indicate greater psychosocial dysfunction. The study can be used in a dichotomous way, where if an individual has a number above a determined cutoff score, that would then prompt psychiatric referral. And the survey is used in that way often in the clinic. However, for this study, we use the raw scores as a continuous variable to potentially correlate with a particular cleft diagnosis and or differences in age groups that we investigated here in this paper. Why were you interested in studying PSC outcomes among individuals with cleft lip and or palate? I know that you kind of mentioned that before, but can you just touch on that again?
Yeah, I mean, I think this is a vulnerable population. It's also a very heterogeneous population and often quite diverse, not just in terms of ethnicity, but also socioeconomic background and whether or not there's private commercial insurance versus Medicaid or public insurance. And I just thought there were lots of variables that could be studied here, and I wondered how much the child's appearance, their degree of deformity, their underlying diagnosis might impact their level of psychosocial impairment, and then whether that changes as they get older. So, when they're younger, is the lip really that big of a deal? And then it has major social implications when they're older, or vice versa. And where does speech or dental differences come in when kids are missing teeth or their smile looks different? I just thought it would be an interesting thing to look into.
Yeah, absolutely.
Can you talk about the methods at all?
Yeah, sure. So again, the study here included patients between 4 and 12 years old, and they were separated into two age groups, those that were 4 and 5, and those that were between 6 to 12, based on the number of items within each PSC survey for the age groups. And since these were consistently collected at routine cleft visits, we were able to retrospectively include surveys that were collected between the years 2010 and 2020 at Tufts Medical Center. And since there were a number of patients that had multiple PSC surveys filled out throughout their visits coming into the clinic, we chose the maximum PSC score within each age group for the study analysis. And we used a Mann-Whitney U-test statistically to determine potential differences in PSC scores between cleft subtypes and the two age groups, as well as a multivariable linear regression to investigate for possible demographic factors that were predictive of the PSC score outcomes. So I think I'll just take a chance to discuss the main findings that we took away from the study. And one of the interesting things that we found was that those with cleft lip and cleft palate had a significantly higher PSC score as compared to those with isolated cleft palate or isolated cleft lip within the younger 4 to 5 age group. Whereas those in the older age group, those that were between 6 and 12 years old, did not have significant differences in their mean PSC score between the different cleft subtypes. But furthermore, we found that patients who were in the older 6 to 12-year-old group with isolated cleft palate and public health insurance had significantly higher PSC scores. Dr. Scott, can you help us better understand these two principal findings that we took away and perhaps give some explanation to why you think we discovered these things?
Yeah, I mean, I think there's a number of different ways this could be interpreted. When I look at the first finding of children that are 4 and 5 with combined cleft lip and palate having the most significant psychosocial impairment, I think of that as almost being a dose-dependent effect of two deformities. And so you have the aesthetic and facial difference aspect of having a cleft lip with a scar and potentially a secondary cleft lip nasal deformity. And then you may have the speech effects of having a newly repaired cleft palate or a cleft alveolus with some differences in the way you talk and your intelligibility. And I think those two things together probably cause more psychosocial impairment than if you just had the lip or you just had the palate. Mm-hmm. That's at least the way that I sort of put that together. And then why that would change as you got older, I'm not entirely sure, but I do wonder whether as time goes on and kids are exposed to more speech therapy or they have a secondary intervention on their cleft palate or more teeth come in, where the speech effects of all of this start to be mitigated by therapy or revision surgery. And that, to me, would explain why, as time goes on, once you get to the 6 to 12 age group, those with cleft lip and palate have very similar impairment to those with isolated cleft lip, because the palate and speech aspect of it has pretty much been mitigated at that point. At least that's the way that I would think about it.
Mm-hmm. Yeah. Okay, great.
And then finally, you spoke about isolated cleft palate and public insurance and having higher PSC scores. That, I think, also could be related to access to care in terms of the ability to pay for or have access to private speech, or the type of school system you're in and the resources they have set up for giving the necessary speech therapy that would mitigate those things we talked about. If you have limited access to that, or you don't speak English, it's not your primary language, and you have limited access to a speech therapist that works with you in your language, then I think that would lead to delays and whatnot that could affect degree of psychosocial impairment. And when we're thinking about kids with isolated cleft palate, they have a much higher rate of genetic differences or syndromes, and potentially higher rates of learning disabilities, even autism. And so that may be those effects may be creeping in there as to why the older kids with isolated cleft palate tend to have more issues.
Mm-hmm. Yeah. Okay. Great. As far as the future directions, we're interested in also potentially correlating results from the velopharyngeal insufficiency effects on life outcomes, or VELO survey, which have been routinely collected in the Cleft and Craniofacial Clinic, associating those with this PSC survey that we discussed today to better understand how speech and speech disturbances are potentially associated with psychosocial disturbance. Any final thoughts or comments, Dr. Scott, before we adjourn?
No, I think this is an interesting area of research, and I think we are surgeons first and foremost, and we always want to get better in terms of our technical ability and our how facile we are at repairing these deformities. But at the end of the day, we're also doctors, and I do think it's important for us to study these downstream effects on the interventions we perform. And I want to congratulate you on this paper and where you took this data and ran with it, and I'm excited to see what comes of the next iteration of it.
Great. Okay, thank you for joining us for this podcast.
We'd like to thank the authors for their commentary, and thank you for listening to our podcast. If you'd like to explore more, please feel free to check out the article in print at the Facial Plastic Surgery and Aesthetic Medicine Journal or online. We'll catch you on the next one.